Before we talk about the nursing care of the patient with altered level of consciousness, let's first describe what consciousness is. Consciousness is the condition in which the patient is aware of self and responds appropriately to stimuli. Full consciousness requires both alertness or arousal and full cognition. Arousal or alertness depends on the reticular activating system. Full cognition depends on the cerebral hemispheres. Remember, this controls all mental activities: thought process, memory, perception, problem solving, and emotion. Your book describes arousal or alertness as wakefulness and cognition as awareness of self, time, and place. Level of consciousness occurs on a continuum, ranges from normal alertness and full cognition to coma. The patient may pass from a normal to a coma within hours or have decreased level of consciousness for months. You should already have defined these terms, but I'll go over them briefly. Confusion: the patient is unable to think clearly, misinterprets stimuli, and has impaired judgment. Disorientation: the patient is not aware of or not oriented to time, person, or place. Obtundation: the patient is lethargic, somnolent, may respond to stimuli, but then drifts back into sleep. Stupor: generally unresponsive, may briefly arouse by vigorous, painful stimulus. Coma: unconsciousness, unresponsiveness, and arousable. The patient may exhibit non-purposeful movement, but there is no attempt to withdraw. Locked-in syndrome: a state of muscle paralysis where there is preservation of full consciousness or cognition. Persistent vegetative state: there is no cognitive function. The patient can have sleep-wake cycles. And brain death: there is a cessation of all brain functions. There is irreversible loss of cortical and brainstem activity. When a person is pronounced brain dead, there is no motor or reflex activity, no spontaneous breaths. Patient can have apnea. There is a flat EEG. The pupils can be fixed and dilated. There is no ocular response to head turning and no caloric stimulus, which I will describe that later. So what is altered level of consciousness? It is any alteration to arousal function of the brainstem or the cognitive function of the cerebral hemispheres, or both. Cause and pathophysiology: there could be structural and neurological causes, such as head trauma, stroke, or brain tumors. If there is swelling in the brain, that is going to cause a direct compression, destruction of structures, and place pressure on the brainstem and affect the reticular activating system. Metabolic disorders and diffuse lesions: changes in blood flow can occur, leading to ischemia and hypoxia. With this blood flow, think about oxygen and glucose. Both are needed for brain metabolism. Without it, the brain cannot form chemicals needed for brain function. So think about hepatic renal failure, diabetic ketoacidosis, and how those can impair wakefulness and awareness. Then there could be a purposely induced coma. Patients that are mechanically ventilated may need to be placed on an induction of coma with medicines such as Pavilon. Third, there could be a toxicology cause, such as drug overdose, alcohol intoxication, toxic waste from liver and kidney disease, and bacterial infections, where there is accumulated waste and toxins affecting nerve conduction. Again, these changes can lead to coma because of impaired oxygen and glucose. Let me give you some memory cues. When you have a patient in your clinical rotation that is admitted for altered level of consciousness, think of the following: A, E, I, O, U. Okay, in English, A, I, E, O, U, standing for alcohol, epilepsy, insulin, opium, and uremia. Think about epilepsy. It is a seizure-disordered discharge that exhausts energy metabolism, altering level of consciousness. Other causes could be remembered by the mnemonic TIPS, T-I-P-S-S, standing for tumor, injury, psychiatric, stroke, and sepsis. Think of how a tumor can compress the brainstem and lead to edema. Stroke is actually the most common cause of reticular activated system destruction. So again, all those causes can be the reason for your patient's altered mental status. Clinical manifestations are going to depend on the location of injury or damage and/or if there is a metabolic cause. Remember that tentorium is the flap of meningeal tissue that separates the cerebellum and the brainstem from the rest of the brain. So if the injury is supratentorial, think about the following signs and symptoms: headache, sensorimotor deficits such as aphasia, seizures, and as a pressure extends in the surrounding areas, possibly visual loss and small reactive pupils. If the injury is infratentorial, there could be a sudden loss of consciousness, unusual respiratory pattern. Well, that is because with damage to the reticular activating system and the cerebral hemispheres, the lower brainstem responds to changes in PaCO2, leading to irregular respiratory patterns. There can be cranial nerve palsies, abnormal eye movements, loss of pupillary reactivity as the cranial nerve is compressed in the brainstem. Now, if there is also a metabolic component, the person may also exhibit confusion, stupor, tremor, axthrixis, myoclonus, seizures, and coma. Also keep in mind that clinical manifestations will also depend on where the patient is along the continuum. Here we have a patient that can have behavioral changes or be difficult to arouse, agitated, confused, anxious, with loss of orientation, leading to a patient that is unresponsive. Please also always remember that the unconscious patient with an impaired gag or swallowing reflex would be at risk for aspirations, since saliva and any fluids taken by mouth could not be swallowed normally, and that is going to significantly impact your nursing care, correct? Let's talk about respiratory manifestations. Normally, we respond to both PO2 and PCO2 levels. If there's damage, the lower brainstem is going to take over, only responding to PaCO2 levels. So initially, we may see changes such as yawning and sighing. Please review the following types of respiratory manifestations: Cheyenne-Stokes, neurogenic hyperventilation, apneic, and ataxic apneic. You should be able to find those in your book. Motor manifestations can help assess the level of the brain dysfunction. Manifestations range from totally appropriate responses, noxious stimuli responses, less purposeful movements and generalized withdrawal, and the reflexive responsiveness, such as the corticate and the cerebral posturing. And lastly, flaccidity. Now, as our level of consciousness decreases towards coma, there can be a predictable progression with pupil or oculomotor response. So spontaneous eye movements is lost and reflexive eye movements are affected. Areas of the brainstem that control arousal are adjacent to areas controlling pupils. So initially, the pupils may be slow, reactive, sluggish, but as the person becomes comatose, they become fixed and dilated. There is two reflex responses. One is called the oculocephalic, or doll's eyes, where there is a reflexive movement in the eyes going in the opposite direction of head rotation, that is with an intact brainstem. If there is a brainstem injury, the eyes remain fixed in mid-position as the head is turned. Keep in mind, you don't want to elicit an oculocephalic reflex on a person that has undergone cervical spine injury. The other reflex is the oculovestibular reflex, or called the caloric test. That is when an ear is irrigated with cold water, it's testing the reflex. Normally, cold is going to cause the eyes to turn to the irrigating side and then to return to midline. Assessment and management for altered level of consciousness needs to begin immediately. Identify any underlying cause. We need to preserve function and prevent deterioration if possible. For lab test, think about causes of level of consciousness changes. Remember that memory cue I gave you? So liver, endocrine, and renal function is important. Evaluate glucose. If we don't know the cause of the altered mental status change, rule out hypoglycemia. When under 40 or 50, there is rapid decreased cerebral blood flow. Check electrolytes. A low sodium, less than 115, can lead to coma and convulsions. Also check osmolality. Cerebral cellular dehydration, if there's high osmolality, leading to cerebral edema if it's low. What about ABGs? Well, yes, helps determine hypoxemia. Liver function tests such as AST, ALT, ADH, albumin, ammonia, all of those can interfere with cerebral metabolism, leading to neurotransmission alterations. Therefore, changes in level of consciousness. Don't forget toxicology screens such as drug and alcohol. Well, what about diagnostic studies? CT, MRI, angiography can help evaluate neurodamage. Is it a bleed, a tumor, or etc.? Angiography can help evaluate cerebral vascular system. Don't forget about possible Doppler and vascular studies, EEGs, looking at the electrical activity of the brain, lumbar puncture, evaluating cerebral spinal fluid. That could help with evaluating for infections such as meningitis. Let's continue with management. What are some possible medications? Again, I want you to think of the possible pathophysiology to help you with this. D50 or insulin if it's low or high glucose. Restore metabolism of the brain. Narcan for narcotic ODs. Thiamine with glucose for malnourished alcohol causes. We need to prevent Wernicke's encephalitis. That is what can result from a vitamin B1 deficiency, leading to a triad and other complications, such as acute mental confusion, ataxia, visual problems, among others. Correct fluid and electrolyte and acid-base imbalances, if the sodium is low, or if there's low osmolality, or etc. How about Lasix and or mannitol? Antibiotics, if it's an infection such as meningitis. Well, what about resuscitation status with fluids? Isotonic, such as normal saline or lactated ringers, or slightly hypertonic to decrease cerebral edema. We need to support circulation and correct the electrolyte and acid-base imbalance. Always keep airway a priority. Support airway and ventilations. Don't forget about nutrition. Does the patient receive nutrition through an enteral source, a G-tube, or TPN? Keep in mind the aspiration risks. Is surgery indicated, such as decompression if there's a tumor, boreholes or craniotomy if there's hemorrhage or hematomas, or a shunt? Monitor for risks of increased intracranial pressure, and if high, we need to reduce. Also control seizures. We're going to talk about the care of the patient with altered cerebral tissue perfusion later on. Keep in mind frequent, systematic, and objective neuroassessments are a must, and that recognizing change is key. So what is the primary assessment tool? The Glasgow Coma Scale, GCG, is the most commonly used. There is other tools, but just be sure to be using the same one from shift to shift. Remember, family members are anxious. It is difficult for them to deal with uncertainty of the prognosis. They might be dealing with feelings of guilt or anger. We need to include family in the care. Is there overwhelming tubes? They need to be caring for each other. They need rest, and reassure that you'll care for the patient and call them if there's changes so that they can go home and get some rest. Support the family. Reinforce physician information and help communicate to the patient. Encourage the family to talk to the patient as if the patient understood. Although it may be awkward at first, with time, they are going to feel it is more appropriate. Hopefully you have reviewed this on your own. I will quickly go over some nursing care. For ineffective airway clearance, maintain the airway. Consider suctioning considerations, such as the time and needing to hyperoxygenate. Also, if there has been a basilar skull fracture, please do not suction through the nares. Suctioning for more than 10 seconds in a patient with increased intracranial pressure can lead to increased CO2, leading to vascular dilatation, increasing the blood flow, therefore contributing to more increased cerebral pressure. Consider positioning, turning every 2 hours, side lying 30-degree head of the bed. It's going to facilitate respiratory and prevent the tongue from obstructing to decrease the risk of pneumonia and decrease pulling. Monitor ABGs and O2 saturations. Risk of aspiration. Assess gag and swallowing reflexes. They can be decreased if unconscious. Prevent aspiration. Therefore, consider if the patient needs to be NPO, position on the side that's not flat if unconscious, and monitor for aspiration, increased respiratory rate, dyspnea, crackles, wheezing, and cyanosis. Impaired oral mucosa. A patient in coma, they're not able to swallow, so they may be having mouth breathing, leading to crusting in their oral mucosa. It's important to brush their teeth gently and placed in the lateral position to prevent aspiration. Keep paralyzed side up and maintain with an oral airway. Risk for fluid volume deficit. If the patient is not drinking, monitor closely. Avoid overhydration with IV fluids that can lead to cerebral edema. Consider the need for diuretics. Risk for injury. Corneal abrasion from the loss of corneal reflex can occur. After correcting ileus, there might be fecal production, but without any voluntary control, the patient may be incontinence of bowel. Risk for impaired skin integrity. The patient can't maintain the movement needed to prevent pressure on the skin. Therefore, it is important to maintain the integrity by turning the patient, checking pressure points, preventing pressure ulcers. Also maintain the integrity of the lips and mucous membranes. Impaired physical mobility. Remember, passive range of motion exercises are critical to prevent contractures. Do collaborative care with physical therapy. Provide support and maintain extremities in functional positions. This may be by the way of pillows in the axillary to prevent shoulder abduction, rolled towels in the hand and fingers. Remember to remove the devices every 4 hours for range of motion. Apply cream to the skin 4 times daily. Risk for disuse syndrome, contractures. Again, this is going to be related to the decreased movement. We need to prevent foot drop as well. Imbalanced nutrition. Monitor daily weights and labs to evaluate nutritional status. Alternative methods for nutritional support, such as through tube feedings, TPN, is important. A dietitian evaluation would be very helpful. Consider vitamin C for wound healing and total protein, calcium, and zinc.